Welcome to this special event of the Guild of Health Writers, Meet the Mavericks. Now, I have to start off by saying that Mavericks actually doesn't mean anything to do with Westerns, and Campbell thought it was something to do with unbranded calves.
I believe it's unbranded calf as well.
Unbranded calf. Nothing to do with that. Maverick actually means, in this context, independent-minded people. So this is a special event by social prescribing and lifestyle medicine. And we have 5 NHS GPs who are representative of a growing tide who are actually transforming primary health care. I believe this goes to the heart of what makes each one of us truly healthy, and thus to the most relevant health care. The NHS was founded on the principles of physical, mental, emotional and spiritual health care for all. And this current approach to primary care is returning to the basics of what we now call holistic, whole person or integrated medicine, or as Michael Dixon said, it's kind of back to the future. Now the Guild of Health Writers, and we've got several original members including me, was founded in 1994 with the mission statement of reporting on exactly that, integrated healthcare. It was a time when someone landing here from Mars might well have thought that healthcare was solely a matter of drugs and surgery, with preventing illness and promoting optimal health very much an occasional bonus. But with the current climate of health problems such as obesity, anxiety and loneliness, this Back to the Future model is really assuming much more relevance and necessity. Identifying social prescribing as a priority for the NHS, Matt Hancock, the Secretary of State for Health and Social Care, said recently, we must take a holistic approach to prevention to reduce the overprescription of unsophisticated drugs in favour of approaches like social prescribing, which address someone's physical and mental well-being. Simon Stevens, head of the NHS, urged GPs to consider social prescribing rather than a pill for every ill. And a course called On Prescribing Lifestyle Medicine is now the subject of an RCGP accredited course, which Dr. Ian Panja, who's the co-founder, will talk about later. Before Professor Tina Van Bortel gives us a short scene setter, I just want to thank the Utley Foundation for sponsoring this event. Neil Utley, the founder, agreed immediately when I told him about the plan for this event. It was literally overnight from America, and I can't tell you how grateful I was to him for putting up the very considerable sponsorship money. Neil's big interest is the provision of music for people with dementia in residential homes, and you'll find a summary of the research of the benefits just there. Sadly, Neil can't be here tonight, but he's looking forward to seeing the video that my husband Alex is masterminding. Meanwhile, Grace Meadows and Lizzie Cody from the Utley Foundation are here and can tell you about the charity. Now, just to explain the format of the evening, after Tina has spoken, the 5 NHS GPs will speak for about 10 minutes each. Then there'll be time for Q&As before we move next door about 8:15 for supper and more networking. And then the evening closes at about 9:30. So I'm going to hand over to Professor Tina Van Bortel, who is Principal Investigator at the Cambridge Institute of Public Health and a member of the Social Prescribing Network, I think, to explain briefly why she believes social prescribing is so important in the context of public health.
Thank you very much, Sarah, and thank you also very much for inviting me to be here today. It's a very exciting event, and to allow me to very briefly, in 5 minutes' time, kick off with a public health perspective and why, from a public health point of view, addressing the social determinants of health and social prescribing is important. So you might have gathered that indeed my area of work is public health. I'm a public health specialist and I'm a social scientist by training. I'm also a professional well-being coach. However, that said, my mum and dad are medical professionals, and you can imagine that at the dinner table from child onwards, there was nothing but talk about the medical profession, medical issues, the health system. So I'm quite literally spoon-fed anything to do with health from child onwards. My mum and dad entered the medical profession as idealists, full of energy and passionate about their profession. They've recently retired, tired and quite frustrated with the medical profession and with care in general. I don't know how that sounds like to you, but I found it really sad actually to see my parents as passionate people retiring in that way, and they are by far not the only ones. This seems to be a recurring theme right across our health and social care landscape, with professionals being pushed to the brink. So, and indeed, it's not just here, it's right around the world that we see that our health and social care systems are on the brink of collapsing, and also we are being faced with unprecedented challenges globally that are complex, that require creative, innovative, collaborative, integrated and sustainable solutions. At the same time, from my public health point of view, we are being faced with massive public health crises, such as, and you might have seen it yesterday, a big crisis in mental health, particularly children and adolescent mental health, but also homelessness, addiction, loneliness, and domestic violence right across the life course. We also see an increasing amount of patients coming to primary care and to A&E with multimorbidity, with medically unexplained symptoms, who can't necessarily be helped in primary care, and also not by just popping a pill. So, to me, it seems quite clear that solving these issues that pertain clearly to the social determinants of our health and also to our lifestyle choices and lifestyle issues is really crucial. Furthermore, we are also being told by health economists, by politicians, that our health systems are becoming completely unsustainable, too costly, with our growing and aging population as well. And that obviously would be very true if we all ended up needing medical care. However, we can do things differently. There is an emerging body of rigorous evidence that we can and we should do things differently from a positive health approach point of view, and also by firmly incorporating and addressing social determinants of health, well-being and quality of life, not necessarily adding quantity to our life. Through connecting and integrating, strengthening primary care and community care as well, through shifting the focus also firmly towards prevention, early intervention, promotion, and to address the social determinants of health and our lifestyle choices and issues. In addition to working with and in primary care, we also have fantastic platforms to work together with and from. Think about our schools. Think about universities, our workplaces, in our communities, sports organizations, other community organizations, obviously the media as well, social media and traditional media, and celebrity endorsement of good lifestyle choices, for instance. And moreover, and this is something with the social prescribing network we are working on as well, we need to also firmly incorporate social determinants of health and social interventions such as social prescribing interventions in our medical and social care curriculums. And indeed, in relation to these community-based interventions, there is a growing body of evidence, as I said earlier on. This morning, you might have heard it, there is emerging evidence around singing and around music, and I'm not allowed to say it probably, but there is a great singer amongst our midst. And we might just put that to the test. But there is a growing body of hardcore evidence that these interventions do work. And from my perspective, it would make absolute good business sense as well to firmly incorporate these social determinants of health and lifestyle choices and healthy lifestyle choices in our curriculums. Because a healthy mind, in a healthy body, in a healthy social and natural environment means strong, resilient, compassionate individuals, communities, societies, and healthy workforce, which sorely makes good business sense. So I hope that from this grassroots movement and fantastic pockets of good practice that we have seen already around the country and globally as well, that we can also increasingly convince the government for a more structural approach and more resources in relation to addressing the social determinants of health and more social interventions, because surely that's better than just popping a pill, which is not necessarily bringing us anywhere towards a solution. I'm surely very much looking forward to the fantastic lineup of speakers we have today and their professional and personal experiences in this respect, and what they are going to tell us more and enlighten us about in relation to social prescribing and the social determinants of health and lifestyle, healthy lifestyle choices. Thank you very much.
So, next we have Dr. Michael Dixon, who many of the Guild are familiar with because he was our president at one point. And he's a practicing GP and senior GP partner at the Calm Valley Integrated Centre for Health. And he is now the national clinical champion
Yes.
for social prescription.
Yes.
for
My
NHS
sins.
England. So anyway, so he's going to explain the origins of social prescribing.
Well,
Talk about background and what's happening.
thank you, Sarah. Yes, it's. I feel I've come a long way because it wasn't that long before people in Clampton used to call me the vicar, and now it's a national policy. So what I'm going to do is I'm going to do the boring bit really, which is to give you the ABC of social prescription, which the other speakers are then going to make colourful references to. So I'm going to look through these questions and right away. Who is social prescription for? Well, it's for the 20% of patients that come and see me as a GP with a social problem. At the moment, we have very dysfunctional conversations because I can't help them with their benefits, their housing and all the issues that they come to me with, yet social prescription can. It's also for the high users of hospital GP services. We know, for instance, in Rotherham and other places, that if you take the 2% people with long-term disease that most use hospital services, not only do they have better lives, but you also reduce the use of hospitals and general practice by around 20%. And then the third category are those with the worst health risks. In my own practice, we took people with type 2 diabetes and at risk of diabetes, we took 150, and showed that in a year you could reduce the number of diabetics by a third. So you can actually convert people to not being diabetic through social prescription. So those are the three main categories of people we're helping. And the model is desperately simple. I think that's why it's caught on, because you need the prescriber, the GP today, but it will be consultants, it will be patients themselves in future. The link worker, which is the absolutely crucial bit of it. That's to say this is not simply signposting people to various activities. You do need this link worker in the middle who can spend half an hour with the patient, understand their needs, their fears, their challenges, their hopes, and then, if you like, give them a bespoke prescription which will enable them to do other things. Now that menu is extremely broad. It can include what Sarah was just talking about just now, music for people with dementia. It can include reading groups, it can include drama groups, yoga, all sorts of exercise and the rest. And I won't list, but if you go to Crawley, for instance, the CCG there, they have something that looks like an Argos catalogue full of all the various things that are offered by the local voluntary services. So it's a very, very simple idea, which is why I think it's caught on. And incidentally, I find that the doctors say it's a woolly idea and don't like the word social prescription, and everyone who's not medical says it's far too medical. So I think at the moment we've got it right because people sort of know what it's about. What's it doing? Well, it's really interesting because first of all, it's offering the patient the really bespoke care that I used to offer 35 years ago, hence Back to the Future. It's taking a patient and really giving them something that actually is going to make a difference to their lives. And then, just as Tina was saying, it is also about addressing inequalities, because the only way you'll ever help someone who's lost their self-esteem, their self-confidence, their feeling that they even want to get better, let alone can make themselves better, is by starting at first base and holding them in the way that the link worker does, and addressing the problems as they see them, rather than, as we tend to do in medicine, to tell people to go off and lose weight, go off and do this, and not actually hold them and give them something relevant to them. Crucially, it's about demedicalising. This is changing the paradigm, just as Tina said. It's about saying medicine is no longer about just pills and prescriptions, because it's not working, just as Tina said. We know that the rates of stress, depression, cancer, obesity, diabetes, just about everything are going on rising. Our current paradigm's not working. And this is about moving medicine in every sense, but particularly in primary care, away from simply having a 10-minute consultation with a patient who's messed up before they come in and then messed up when they go out, and beginning to take a hold on the health and well-being of the local population in general practice, and we'll see some very good examples of that later on. The crucial issue here is about activating those who were not activated or able to help themselves prior to their social prescription. And in those third of patients who we converted from being non-diabetic or at risk to no longer being so, we found in each case it was because their patient activation index had gone up. Their whole locus and view of life had changed. And that led to all sorts of virtuous circles in their lives, and that should add also in the lives of people around them. And then finally, what we're going to do, as Tina really, I think, described, is to create a new society, one in which the infrastructure and social capital, in terms of the volunteer offers, creates a society where you actually no longer needs social prescribing, and people are actually made well rather than alienated and ill, as currently in most of our society. The Social Prescriptions National Network, and thanks Tina for mentioning the National Social Prescribing Network, is really quite an interesting story. I'm going to quickly, rapidly tell you about it. It started on a train around about Reading 3 years ago, a discussion between myself and the co-chair, Marie Polly. We thought there needs to be a national movement for this. So we had this first meeting in London where we invited anyone who was interested. We had a room for 100 and 150 wanted to come. And bit by bit we found, and some of the speakers tonight will be amongst them, that all over the country there were pockets of people doing this almost spontaneously, who realised that we had to look differently at what medicine and primary care were doing. That went on 3 months later to a reception in the House of Commons, when NHS England came up to me and said, well, you seem to already be doing this, can we join forces? We were thinking of having a department on this. And it's gone like topsy, because that's only over the last 2 years. We now have over 2,000 members in the National Social Prescribing Network, increasing number of foreign members. I had to go and speak to the national conference in the Netherlands last week. And this is becoming an English, a national and a world movement, looking at some different way of how we help individual patients, but how by helping lots of individual patients and building up structure, we actually change the community. And it's also quite an interesting, different way of doing things, in the sense of frontline clinicians and people that actually started it now working with the establishment, NHS England. Sometimes the frictions, sometimes they have to do the splits, because you find, independent people and people with a sort of slightly centralist hierarchical view of things think differently. But it's a great example, I think, of cooperation. So we now have a large national social prescribing network, and we are building up the evidence. And I'm going to leave this production which we did, which is a review of the evidence for anyone who wants to see it. And incidentally, here's the NHS England pamphlet we just produced on what is social prescribing. Now, in a sense, you might say the evidence is common sense, because the increasing evidence, for instance, from the National Garden's report here at the King's Fund last year, that gardening increases your life expectancy by 5 years. We know that social isolation is as dangerous for you as smoking, and Sarah's already alluded to other evidence. So in a way, these various interventions are already proven. So in a sense, social prescription is proven. And the problem with actually getting evidence, it's a very complex intervention with lots and lots of nudge effects after it happens, and so quite difficult to measure it. But the main reason people call for evidence, in my opinion, is it's the NHS's best way of keeping good ideas out for 10 years. And that's what they've been doing, but they're not succeeding because it's going far too fast for the naysayers. And there is actually some good evidence anyway. We know from these 3 CCGs, so you're talking about a population here of well over 1 million people, that you can get a 20% reduction in the use of the NHS when you do it well. Incidentally, in Rotherham, they found that in the over 80s who were long-term ill, though that was 20% over 2 years, at 5 years, which they are now, those patients, those over 80-year-old patients, are using NHS services 50% less than they were at the beginning of the trial. So you do get this change in attitude, change in perspective as a rolling thing. Even Rotherham showed that you saved £2 for 1 year spent in year. In my own study, London School of Economics looked at our research on diabetes and said that we'd save money in year. The big problem, as you all know, is that the commissioners are not even interested in anything being cost effective anymore. It's got to actually save money in year, in that year's budget. That's how short term we've got. But oddly enough, social prescription could even do that. We're going to try and strengthen the evidence by trying in future to get evidence, if you like, in real time, just like Tesco's and Debenhams and all these shops. And the way we're going to do it is by having a common evaluation network. And even that's been quite an interesting story, because we went into a room and came out with one, and the front line all said, absolutely no, we don't accept that. There was a rebellion, and then we said, right, we're going to start all over again, and we're going to involve everyone in doing it. And miraculously, we have now got an evaluation framework that will be coming out in the next month or so, which will unite all those providing social prescriptions. So as each GP types into their box, everyone will know what they're doing. 2 minutes? Right, okay, so I'll quickly race through the rest. This was a comment at our first National Social Prescribing Evidence Conference, which was in Birmingham, no, Manchester, and I think it's true. The current uptake is going like topsy. The South Yorkshire STP is taking up full time. Manchester and London are planning to. 12 CCGs have already taken it on, and the common pattern is about half local authority, half CCG funding it. But watch this space. I believe it will be universal within the next 3 years. The future, is this a volcano exploding, or is it a new dawn behind an old volcano? I think actually there's great hope ahead, and I'm going to very quickly flash through slides showing what I think new general practice will look like. That's my social prescriber, Ruth, that's our surgery. These are the gardens, all run by the patients themselves. A herb garden, a garden the shape of a man with all the herbs according to the space they are. Prince came and saw us. This is our new Anton Chekhov garden. It came from Hampton Court. We're about to have a community garden behind it. A cafe, which is as important to providing healthy food as in people meeting in groups and socialising. Acupuncture, walks, lots of activities organised by the patients themselves, and here's the patient group that organises it. And it's all about everyone helping themselves. The bird finding the seed, the rabbit watering it, the monkey fertilising it, the elephant digging it in. It's all about us all working together and not working separately. And finally, those are some references. We've got our second national conference, the 6th of November here, and our first international conference will be in June next year. So do come and you'll be most welcome.
Thank you so much. Thanks so much. I never realised the background to it, and I certainly never realised that Reading was a place for inspiration. Now, our next speaker is Sam Everington, and he's really a pioneer of social prescribing at Bromley by Bow Centre, and is now chair of Tower Hamlets CCG. And your own Bromley by Bow Centre has 100 projects under its roof, supporting the wider determinants of health. So you're going to talk to us about your experience. Yeah. He's also the songbird. So if anybody wants a sing-song afterwards in Norwegian,
1926 is when this started. Peckham experiment, if you want to look it up on Wikipedia. And the Peckham experiment had swimming pool, gardens, everything that was about what Mike was talking about, social describing. And it got closed in 1950 because the NHS said it wasn't needed anymore. This is the Peckham experiment Mark II, but I would suggest to you it's not going to go away. What is it all about to my patients? So the answer is, when Mike and I went to medical school, we were taught to work out what the matter was with somebody. What social prescribing is a focus on what matters to people. And once you start thinking like that, you change the way you think as a doctor, and you utterly focus on the things that are important to patients, not what you think is important as a doctor. What I'm going to do in a very short time is take you on a lightning tour of some of the 100 projects. And I've got 10 minutes to do it. So Tower Hamlets, very deprived in the city area, but a very mixed population. I was at the bus bomb 12 years ago and came back actually. There's a very strong message here about social prescribing, thinking how important our centres were, because that's what you will see at our centre. And how often do you see that in our society? If you bomb somebody, you hate them. If you hate them, you don't know them. So a key part to social prescribing is bringing people together. In a way, by the way, at Bromley by Bow, they would never realise this is kind of secretly our secret plan. Of course, looking at the wider social determinants of health, this is a picture from Mile End Road. We know it as Chicken Shop Mile, 5 chicken shops, 42 chicken shops per secondary school place at Tower Hamlets. This is killing people at Tower Hamlets. I recommend, by the way, to my patients McDonald's. That's a healthy end of the market. This is how Bromley by Bow started. Patients in the East End, they say it straight, known as dog shit green. You will have lots of examples of dog shit greens across the country, but actually that's what it looks like now, because we got given a management contract over 30 years to take over this 3-acre park, and it's completely transformed by the same architect who's done all these projects. You can see it's a beautiful space. This is the entrance. This was an arch that came from the Strand in the 30s, was put on the side of the park, God knows why. Project, by the way, with Tesco's, they paid 20,000 for this. We said, what can we do for you? By the way, that's what this is all about. Partnerships, and you could see them almost saying, Tesco's, we're Tesco's Almighty, what could you possibly do for us? Well, a year later, actually, we'd given them far more than 20,000, because what we'd help them with is think about how they could persuade the Bangladeshi community to come into Tesco's. And of course, you come into the courtyard, beautiful space, beautiful smelling wisteria, really, really important. Patients are terrified when they come and see you, and sometimes medics forget that. Everything here is about relaxing people down. That's a stone sculpture by one of our sculpturesses. We have a fish pond there with a fountain, why wouldn't you? And this is a project that started, it's not this anymore, but it started as the Leg House and Flower Arranging Clinic. Why not? Actually, this is a message about getting people, empowering people to do what they want to do, what they're passionate about. That's what the district nurses want to do. But she's got rid of the leg houses by good practice, but also bringing the joy back into patients' life. And they're now called the Young at Arts group. That, by the way, is a story of also sharing the space. This is our waiting area. Okay, completely open, no grills, no CCTV cameras. Do we have any security problems? No. You can walk into Bromley by Bow in all sorts of different ways. You can walk behind the reception desk as a patient. Okay? Is there problems around confidentiality? No. Actually, what happens is amazing conversations. Of course, we sit next to each other. I don't wear a tie. I never use any of my titles to patients. I'm Sam to every one of them. I dress scruffily, as my mum would say, but there's method in the madness. It's about actually a partnership. Notice how we're sitting next to each other and working together. Now, don't get me wrong, there are occasions as a doctor where you have to be very firm, actually with other doctors and patients. They're the worst. They come in, they know all the stuff, they think they can control. Sometimes you just have to say, sit down, shut up, and sort you out. The skill is working out what the patient wants and needs in the relationship. But what you can't have is the old, typical old-fashioned approach, which is I know best, or I know what the matter is with you. It's critically important. Going back to that statement earlier, what matters to you. Now, this is my ECG. So the health and safety and all that sort of thing says you've got to put frosted stuff on the windows, okay? So it makes you feel as if you're working in a toilet. I didn't want to do that, so what did I do instead? I got our lead window artist, Sheena, who's amazing, one of the founders of the centre. We did my ECG and she's turned it into stained glass. This is what happens, by the way, if you put lots of people under one roof, you get the most amazing ideas coming from this. And this is just some of the work that she's produced. As you can imagine, it's absolutely beautiful. And then we have community care. So we have people with learning physical disabilities doing the most amazing pottery. So Murade is one of our artists there, but she actually does lots of work actually within the community care group. Any excuse for a party, by the way, at Bromley by Bow, any excuse, you name it, we'll find an excuse for it. This is just an example of how the park is being used. And there's an egg and spoon race there, a whole raft of things. I'm not going to tell you who's a very senior person in Barclays and who's a patient. I'm going to leave you guessing. And of course, the leftovers of the Paralympics, actually, guess what? We're doing a whole raft of things in the park and space. And I won't tell you also who is the stone sculpturess, but that's what she produced. And in fact, the first thing that was done in this park, you saw the picture of it before, this was the first sculpture, which she did with one of those, you know those road kangahammers things? And it was just amazing. You can imagine all the estate were thinking, what the hell is going on? It was a bit like the ice cream van when it comes around, you know what I mean? It was a call to arms almost for the local community. English second language, absolutely critical. Actually, 40% of my patients don't have English as their first language. Absolutely critical. We do jobs advice. So we roughly categorise what we do into employment. If you get a job, you will be healthier. Education. If you get an education, you will be healthier. It doesn't matter what it is. Okay. If you get involved in creative or spirituality, however you want to class it, you will be healthier. And finally, there's the environment. Environment is absolutely critical. We have apprentices. This is our artist. So we have a director of art at Bromley by Bow, Frank Graeber, who does amazing things. So when they were building an estate down the road, actually, he was on the street. So there's a lot of opposition locally. He was on the street, actually, doing artwork, and as a way of actually helping people understand what this new building was going to be. It was actually a hospital that was knocked down. Cooking, absolutely critical. Gardening, absolutely amazing, really, really important. I did this presentation at the National Gardening Scheme. These are people who open up their gardens, fantastic people around the country, and get tons of millions of pounds for charity. And there was a sea of people who were all over the age of 70, but they were kids and they were healthy. There's such a strong message, and of course Mike made that point about at least 5 years. You put an 80-year-old in a hospital bed for 10 days, they lose 10% of their muscles, and it's the equivalent of inactivity for 10 years. What I saw at the National Gardening Conference was people completely alive and far younger than a whole raft of patients I had to help. Allotment gardens, gardening training we have there, and I love to show this picture because these were two people. They're happy for me to tell you this with learning disabilities, and we love a love story. They're now a partnership, actually, a real partnership. So anything we can do that's around love would be fantastic. Granny's in the kitchen, and of course this is our Connect Zone at front, an internet cafe, but it's like a John Lewis experience. You go in and the social prescribing team say, how can I help you? It might be how to use the computer, it might be a job. We celebrate all the people who pass our courses. We're a community university. We started as a church. This is my wedding 4 years ago. This is Lord Mawson, who founded the centre, who's a vicar. We have many things in common, but one of them is champagne. So rather than have the blessing at the end, I had him serving champagne to everybody. This is our nurses, and I just want to give you a phlebotomist with no formal education, knows all the patients, amazing clinician now. a nurse who basically visits all the patients with complex care terminal illness, which means 13,000 patients Monday to Friday. I'm on Monday and Friday, I'm on call, hardly ever do a visit, because actually it's all proactive care. And one of those people there is my wife, also a partner of the practice, but also a nurse. So lots of unusual things happening in this setting. It's a patient aged 50 who got throat cancer, lost her job, came on an art course, then learnt IT, back in employment. It goes further. This is spreading. This is entire hamlets, the Princess Trust, combined with one of our practices. Why wouldn't you do that? This is one of our other health centres. This is one of our GPs who's doing an Exmosaurus project with kids. So they're doing paper mache Exmosauruses and washing them actually in pools, so learning how to manage their eczema. Why wouldn't kids do that? This is the reg bag. Steve, I haven't got time to go into this, it's running out. This is a cafe that's reduced hospital admissions, acute psychiatric admissions, by a third by setting up a cafe that's open 7 days a week, staffed by health workers. How amazing is that? This is owl therapy, particularly for kids with autism. This is a project where the nurses have reduced terminal illness death in hospital from 50 to 60%. How outrageous is that to 14%? I provide my mobile phone number to all my patients, my email address. They can ring me anytime, even on the west coast of Scotland, out at sea. That's probably my very 100 projects. You're very welcome to come and visit, and we'll give you a taste of some of the other many projects we do. But just always keep in mind what this movement's about is not what the matter is for you, but what matters to you.
Well, I don't know about everybody else, but I'm just feeling as if my soul is singing after that. Talk about putting the joy back. Our next speaker is Dr. Helen Kingston, who's a GP in Frome. There's obviously a bit of a West Country mafia here. Yeah. No surprise that I actually have done there as well. Helen identified loneliness, I think back in 2013, as one of the big problems with her patients, and set up a project called Compassionate Frome, which has really taken off. Now, interestingly, from our journalistic point of view, it was a piece that George Monbiot wrote for The Guardian, which really provided the trigger for Helen to realise how widespread this problem was. And since then, the project has spread to, I think, several other places, nationally and internationally. Over to you.
Thank you very much. So my name's Helen. I'm one of many frontline workers in the NHS. And like so many, I came into the NHS with a desire to make a difference. I work in a team of human beings, and together we do our best to look after fellow human beings who happen, many of them, to be our patients. Daily I meet the complexity, the gentleness, and sometimes the flawed humanity of the people around me. And it is the joy of my work in these moments of connection and shared understanding that is what Compassionate Frome is all about. By recognising the value of relationships and the human aspects of healthcare, and treating patients with kindness, compassion and understanding, and then extending that approach too to the workers who are doing their best in difficult circumstances. We acknowledge that each of us is so much more than just the sum of our qualifications or our diagnoses. A little bit like when I became a GP 25 years ago, I was asked to do my best. I still try and do that, but sometimes life on the front line is intense and less forgiving than it used to be. And it is the human factors which keep our NHS staff committed despite unrealistic workloads sometimes and the constant threat of complaints. I get up in the morning because I love the people I'm looking after, I love the team who are around me, And the journey in Froome has been about creating that great team and helping us all to work together to create a great environment where integration is the norm. So we focus very much on what is most important. That may be practical. I have a patient with MS who went into hospital and her respite care got cancelled because her care episode was closed by social services. But on a Friday, we have a social worker in the practice. So I was able to go and talk to Kate, our social worker, about this problem and have a discussion and get it sorted out and fixed there and then. That practical assistance makes a huge difference to her and to her husband. It's about emotional support. Time and time again, people will come in when life is difficult. Sometimes there are medical issues, but a lot of times it is life that is difficult. And I've had the privilege over 25 years of following through other people's lives and then following through mine at brownies, at swimming club, at school gates. You grow up with one another, and that just being there for one another makes a huge difference. And integrating that with the necessary medical care, because sometimes pills, operations, medical procedures are the right thing, but just recognising when it is and when it isn't. And recognising the value of relationships and the value of the whole system working together. And I think that is the thing that has made the most difference to my working life, that I've got citizens' advice here on a Friday, so that if I've got somebody vulnerable with mental health issues who suddenly gets a PIP form that needs filling in by the 22nd or they'll lose their benefits, I have got that resource to be able to offer them an hour with Iona to sit down and get that sorted. And we can do that together because they're there, and I know that when I say she'll do that, that will happen. This has been a very much a population-based approach. So 5 years ago, I was trying to do my best for individuals that happened to come through my door. What we've set up in Froome within primary care is a systematic approach dealing with our whole population. No cohorts, no inclusion and exclusion criteria. If you've got a little bit of mild anxiety or slight touch of pre-diabetes, you do not have to reach a crisis point before you can be offered help. It's based on a clinical assessment of does the person in front of you need help, and as much as possible it is holistic and collaborative. I don't think it's news now, but it was news. Loneliness and social isolation can be as harmful to our health as many of the traditional things that we've looked at to intervene with public health, such as smoking. And the amount of time I spend, and other NHS staff spend with an individual, is a tiny, tiny proportion of the time they spend on their own, with their family, with their friends, within our community. So trying to harness all those other resources that are there within our community to help them along their way. And this is a study that looked at the impact of social relationships on health and on mortality. And you can see that smoking, drinking, not being the right weight, drugs for hypertension, air pollution, lots of things that we traditionally focus on are dwarfed by the impact of having poor social relationships. So when we set out with our project in Froome, we tried to mould the medical elements. So that's the elements at the top there. We've got a clinical hub, we've got near patient assessment facilities and in-reach nursing into our hospital, with the community elements. So our one-to-one workers are called health connectors, the equivalent of health coaches. We have community connectors who are interested members of the public, part of our community who have done a brief training on our website and on understanding how to access support within the community. And they go out and speak to neighbours, to friends, to family, perhaps people at work when it's appropriate, and say, did you know this group's happening? Did you know you could look here? Did you know you could telephone? We've got over Mendic now over 700 of those people. Each of them speaks to about 20 people a year, and suddenly 14,000 conversations have happened with no funding, no regimented infrastructure. They are not volunteers with CAB checks and appraisals that are needed every year. It is just mobilising the community to help themselves. We've had 45,000 hits on the website of resources in the last year. And then other people, because we're visible, because this is happening, have come on board. So we work in a multidisciplinary way with our district nurses, with our hospice, with the older people's mental health team, with our adult social care systems advice. Those people coming on board and working with us, and that integration of care wrapped around the patient has made a huge difference to us. Lives are complicated, and there has to be an interplay between the social, psychological and medical needs. We need to be flexible and respond to the person, not their medical condition. So we've tried to be pragmatic, clinically led, front-line use of quality improvement, and improving the care for our patients and for us in the system, working to try and make that happen. It's breaking out of silo working and wrapping the care around the individual rather than them having to mould around the resources that are there. And it's built a strong team ethos, supporting patients and carers and working within the system. It's treating staff with kindness too, and re-enabling us to deliver the sort of care we would be proud of and that we want for ourselves and for our families. So this is our small team of paid workers, and as I said, on top of that, there are 344 community connectors in Frome, more across the rest of Mendic. And it works because we're doing what is best for the individual. We're allowed to be creative. Patients feel it belongs to them, and staff enjoy their work. We've got some statistics to prove what we've said, and we've got the financial impact assessments that show around £6 saving for every pound invested in this scheme. There's been different sets of data. The CCG current data has moved our baseline and the baseline increase across the rest of Somerset and reduced it to 6.2% of the emergency admissions recently, but they acknowledge that we've definitely made some savings. We can achieve much more together than individually. We mustn't underestimate the power of relationships. Scaling up requires a systematic approach and the capacity to work together and have multidisciplinary conversations. It has to be holistic, and we must support carers doing what is best for the individual who works.
Well, thank you so much to Dr. Helen Kingston, because that was completely fascinating and really shows what mobilising a community to help itself for nothing can actually achieve. Ian Panda is a GP. You may also have seen him on telly because he's a presenter on BBC News and BBC World News. And with Dr. Robin Chatterjee, Ian created the first ever course on prescribing lifestyle medicine for general practice accredited by the RCGP. And he's now going to talk about why he believes a lifestyle prescription should become the first treatment most patients are offered, what it embraces, and what the feedback is.
Thank you very much. Thanks. Good evening, everyone. I just want to say that what we've heard so far has just blown me away, and I don't want to sound trite when I talk about what I'm going to talk about, and it's very unusual for me to talk about something that's more scientific than someone who's already spoken, because I'm an arts and music guy all the way. But the thing about my presentation and lifestyle prescriptions is that I was a bit lost in medicine, to be honest, and I realised that a lot of what we were doing in the consulting room just wasn't helping patients. And actually, as we've heard already, the power of community and the power of communication and interpersonal relationships and what makes people tick is probably the most important thing. I'm going to shift the focus a little bit to something more biological, and I'm going to race through what normally takes me a day to teach other GPs and healthcare practitioners in 10 minutes, so stick with me, and hopefully it will go well. Lifestyle medicine, this is really the subject of my talk. So lifestyle prescriptions come out of lifestyle medicine, and this is one of many definitions of lifestyle medicine. There are so many on the internet. It was actually coined by a chap called James Ripp, who is a cardiologist based in Florida back in 1989, but it never really took off, and he wrote the first textbook on lifestyle medicine, which was very, very heavily focused on cardiovascular disease and preventing it. But it's always been seen as a bit of a Cinderella specialty, and I want to sort of move forward a little bit to the year 2012, when this document was written by Claire Gerarda and Ben Riley, who are two well-known GPs. And this document really was trying to predict what the NHS might look like in 2022. It was also around the time that I was so disillusioned with general practice that I thought, you know what, I'm going to just take up painting and decorating or something else. But they were right. What they said was that people will be living with more and more multi-morbidity, so lots of different conditions, which means that their care is going to become much more complex, and that we'll be needing to promote healthy lifestyles and also engage patients in their communities, as we've just heard about. I'm going to race through this. One of the key things that I love about this, and I'm a real passionate advocate of generalism, anyone who knows me will know that I go on about this till I'm blue in the face. It needs a generalist approach. If you're trying to move someone from 0 to 1, or 1 to 2, or 3 to 4, you need generalist skills, someone who can connect up the dots and make links. It's no use having someone who's a specialist. They go from 7 to 8. Just want you to bear that in mind as we move on very quickly through, I've got 20 slides by the way, very quickly through some comments. So this is from Richard Smith, who was an ex-editor of the BMJ, very clever man. It's not a study, it's just a comment piece in BMJ opinion. But the bits that I want you to think about is what's been happening in medicine over the last 50 years is that we are trying to practice evidence-based medicine, and what that does is that it looks at studies, which is exactly what we're meant to be doing, but most of those studies, as Richard points out, are based on people without multiple conditions. Yet on the other side, we're meant to be promoting whole person care and all of the things that we've been talking about this evening. And the two things seem in absolute opposition, which actually creates a lot of confusion for GPs, a lot of confusion for healthcare practitioners. How can you follow evidence-based medicine if you're meant to be dealing with the individual? So, and there's loads of articles that you see about lifestyle medicine. I'm not going to go through them all, but this is just a reflection of what you see in GP press and in the national press. This is one by Sarah Bosley, I think, from The Guardian, talking about, again, a greater role for GPs, what else can we take on? So this all comes off the back of non-communicable disease. This is a slide from the World Health Organization website. And I don't want you to think traditionally, this is all about tobacco and heart disease and all of those things. I want you to think about other non-communicable diseases. Autoimmunity, for example, is on the rise. Type 2 diabetes, heard about that, we're blue in the face. And other things like mental health conditions. These are all non-communicable diseases, and they start with non-communicable symptoms. This is one of the things that really fascinated me about these people that come in often labelled as heart things, or you sort of think, oh, I've got someone in their head. But actually, if you think a little bit deeper, that's not always the case. And sometimes nebulous symptoms are a starting point, an early warning sign that something is developing, or there's some sort of systemic dysfunction going on. This is the problem that we've got at the moment. This is the way that medicine is traditionally practiced. So you've got the patient in the middle, which is the elephant, and you've got a neurologist and an orthopaedic surgeon and a colorectal specialist and the ENT specialist, and all of them are looking at their bit. And although we try very hard in primary care as GPs to connect up the dots, I think we do a very good job given the constraints that we work within. Are we doing it well enough? So what's the difference between the medical approach and the lifestyle medicine approach? They are slightly different. So a medical approach, and by that I mean biopsychosocial, is very much disease orientated. It's a name and blame game. I don't mean that in a disrespectful way, but that's the sort of diet that we've been brought up on, certainly the kind of medical training I had. So if you think about your local gynecology clinic, you have pathways based on conditions leading in early pregnancy, cancers, and it tends to be specialised and based on symptoms. And the focus is on early detection of disease, whereas a lifestyle medicine approach really looks the other way. It's orientated towards health and prevention. And the key thing is that it can be individualised. It's not about protocols. It's not about that. It's actually it's about the person in front of you at the time and what you can do to get them better. So my vision for healthcare practitioners, and this is actually from the learning objectives from the course that I've created with Rongan, is I wanted them to have something that would work immediately. So you come along for the day, we install this software, if you like, that you can suddenly use from Monday morning. Is that possible or not? Well, we think it is, and I'll talk a little bit more about the course a bit later on if I don't run out of time. But this is really what I wanted to do, and I think we've achieved it. And for that, you need a little bit of scientific knowledge in terms of going into more depth and possibly refreshing yourself in terms of physiology and biochemistry. But the key thing is changing how you think about the patient. So we've already talked about systems thinking, and this is more about biological systems and how systems link to symptoms, and how all of these systems are continuously intercommunicating and interconnected. The other thing is that all the things that we do as human beings, they make us ill, but they can also reverse your symptoms, and they can reverse chronic disease. Low-carb diets is a popular example. I'm sure none of us in the room have not heard of Tom Watson recently, but low-carb diets is just an easy example of how disease can be reversed by looking at these things. Sorry, I'm racing through it, but I've really got a lot to get through. So this is something that I came up with just by instinct. This is how I think when the person is sitting in front of me. This is step one to getting to your lifestyle prescription. I've just named it something called the symptom web. The problem with medicine at the moment, in the era that we're in, is that you get a lot of what and no why. And I wanted to turn the what into why. Well, you've got irritable bowel syndrome, goodbye. You've got fibromyalgia, not good enough, frankly, in 2018. And, focusing on the biological bits alone, these are not exhaustive, but these are the factors that give rise to the symptom. In the middle can be any non-communicable symptom, anything. Painful joints, headache, a rash that's unexplained, tired all the time, bloating, it doesn't matter. But these are the things that, if you tighten the screws up on them, easier said than done, because again, that's to do with motivating the patient and all of those things, and that interconnection, which is the key thing, the relationship that you have with them. Can't really do much about genetics. Environment is really to do with social prescribing. That can be anything from having no money to living in a house that's ridden with mould. How many of you doctors ask your asthmatic patients about mould in the house? I never used to, but I do all the time now. So this is step one. Step two is Rongan's 4 pillars. If you've not heard of his book, The 4 Pillar Plan, it's a brilliant, accessible book on lifestyle medicine. He's turned a lot of complex science into something that's very accessible. And then this bit here, the how, what, and when. We're going to go through a quick example of this. So let's go back to this. Gary, 37-year-old hairdresser, comes in saying that he's basically got intractable heartburn. He's had 2 normal endoscopies. He doesn't have an infection called H. pylori that can give you heartburn symptoms. And he's on maximum medication. He's tried everything. this is what is known as an oh shitter in general practice. You know, you sort of think, what am I going to do with this guy? Am I going to send him back to gastro? He's just come back. What do I do? You stick him into the symptom web. Actually, he's really healthy. The only thing he had in his past medical history, which of course we have in front of us on his computer screen, is he had loads of ear infections when he was a kid. He had a myringotomy, sort of an operation on his eardrum. So he had about 40 sets of antibiotics through his lifetime. And then when we dropped into his pillars, he was actually pretty healthy, goes to the gym and all that stuff. But the how, what and when of his eating was appalling. So he stands up, he eats breakfast on the way to work while he's walking. He has a mainly beige diet. He's always on his feet, doesn't really sit down and digest his food. He eats very quickly and he eats his dinner late. So one of the things that I did was I messed around with those three aspects of how he eats. I said, you've got to sit down and eat, you've got to chew your food, because if you chew your food, salivary amylase works and starts to break down carbohydrates. You need to reduce your carbs a little bit. This is not about low carb diets. He just loved pasta and croissants and lattes and stuff like that. And this is what a lifestyle prescription looks like. Most of my patients get it on a post-it note. Recently, I went to the ENIS conference. ENIS is one of the software systems that GPs use. So we can go into the consulting room and the GP's tapping away on the computer. ENIS runs about 60% of those systems in the UK. And actually, we've come up with a template that can integrate with ENIS, but actually they don't need that. This goes on a piece of paper. So what did I do with this guy, Gary? It's very simple. I changed what he ate, how he ate, and all of that stuff. And I put him on a probiotic because his gut flora, I felt, were not good because of his recurrent ear infections and recurrent antibiotic use. Some of you in the room will be thinking, oh, hang on, what's all this? Probiotics don't work, do they? According to that study from Israel with 25 people, they do work. You just have to know what to use. And this is part, I haven't got time to go into that at the moment, but this is part of the knowledge base that GPs don't have. Sorry, 1 minute, okay. So this is like a real oh-shitter. This is the guy that comes in as my last patient on a Monday morning, normally at about 1 o'clock, when I've seen 25 other patients. He's got all of this stuff going on, but the point is, by the end of the course, most of these people, you'll be able to manage them, not just because of other tools. I think social prescribing is, as I say, more important than all of this. But this is just, and look at the team that you've got around you. It's very selfish of me to put GPs in the middle, but there's all these people. If all of these people had a little bit of this knowledge, it's that nudge effect that Mike was talking about. You're able to get these people off to a good start. The course itself, 100% of people that came said that they'd recommend it, 100% said it was a high quality event. And we have a closed Facebook group, and the kind of stories that we get on there are absolutely unbelievable. These life-changing, these people with chronic conditions that have now effectively gone away. And that's just by thinking a little bit more deeper about the biology. So yeah, thank you for listening. Sorry that was so rushed.
I do feel awfully like a cross between a nanny and a sheepdog. But anyway, that was a splendid canter through, thank you. And our last speaker is Dr. Campbell Murdoch, who I met through another GP in the West Country. And he's going to really report on his experience of metabolic health and lifestyle medicine, in particular prescribing low-carb diet and exercise.
Great. Thank you very much. And thank you for having me here tonight. I'll give you a bit of my background actually and show what links into everything this evening and make sure that you know I'm not just coming at this from a very linear low carbohydrate diet perspective. So I'm a GP by background, went to GP because I wanted to help people. And then studied sports and exercise medicine late 2000 with an interest in what it is to be human, and with that, how can you kind of optimise human health, well-being, performance. I thought athletes do a fairly good job, and I wonder what it is that achieves that. And as I was studying that, it steadily dawned on me that they were looked at their mind, they looked at nutrition, they looked at movement, and they looked at the world around them. British psychology take their beds around with them, and then it kind of dawned on me it's because they're humans. And then I reflected on my medical practice and wondered what on earth we were doing in medicine, focusing on a disease and a reductionist intervention with a drug. So that set my brain off on a funny angle, frustration, became a GP partner, spent 4 or 5 years, 14-hour days, working hard, which I don't mind anyway whatsoever. However, when I realised I was working hard for limited benefit to patients, I became increasingly frustrated. Then about 5 years ago, I thought, what can I do about this? So I decided I only needed to work 3 days a week as a GP to pay the mortgage, and then I had 4 days a week to follow my passions without needing to worry about being paid for it. So from there I sprung into what is my why, and my why is optimising individual population health and well-being, and then the decision, how can I have the biggest net benefit on the world as long as I'm on this earth? And it took me on a journey. So now I'm GP, Chief Medical Officer for diabetes.co.uk, which I'll touch on at the end. Work for NHS England, training healthcare professionals in improvement, and also work for Public Health England in their physical activity arm. Put the slide in the middle there, hope. One of my beliefs is humans do well when they have constant hope. And it's a real story behind, I think, the social prescribing and any lifestyle medicine intervention. Very briefly, because I'm going to focus on low carbohydrate diet, but I'm desperate for people not to frame. This is a model I came up with, like Ian's model of how in 10 minutes can I quickly capture what's important to people without having to do a three-week questionnaire. Mind, which is beliefs, values, mood, mental health, emotions. Movement is functional movement, so moving to do things as well as physical activity. Nutrition speaks for itself. World basically is everything external to you. The most important that I believe in there is relationships, but in there there's also money, housing, environment, transport, all the rest of it. And body, and in body is anatomy, physiology, sleep, microbiome, drugs. So all of that. So we're thinking about all of that, and on anybody's journey, it encompasses all parts of that. So now to the kind of the linear medical bit. So this is a patient, 24 years old, 174 kilos, BMI 51. He had a skin condition in his arm called keratosis pilaris, which is the kind of bumpy skin people get. He used food as a coping strategy, sort of a lot of his social life orientated around it, and also when he had stress, he would go to food to try and cope. But he had no other medical problems, wasn't diabetic. The kind of opening was everything has failed. He'd been through all these tertiary services in the NHS, and everything had failed, and basically he now had bariatric surgery on offer, which for himself and his mother seemed like an absolute disaster. I'm not saying sort of anything against bariatric surgery, but for him at this moment in time, it wasn't the right thing. So the question was, can you help? And I guess sort of reflect in the room. What would you do at this moment in time? Just before I go on to that, I started with the what matters to you, which is really important, really, really important. So for him, it was being able to go out of the house and know that he's going to fit into the seat that he was presented with, be able to buy clothes in the shop without having to order them online, were his 2 key things. And also, he was going to go off to university in about 3 months' time, and he wanted to have lost 3 stone by the time he went to university. So we did a load of biochemistry tests, and I'll touch on this after this presentation if you're interested. But he had sky-high insulin levels, really, really high, and it's a big problem with body storing too much fat if you've got very high insulin levels. So biologically, what made sense for him was a low carbohydrate diet. In fact, I was careful not to push him too hard with his coping strategies around food. He actually opted to go on a ketogenic diet, mixed with intermittent fasting, and he used swimming for relaxation as opposed to exerting himself. So he lost 3 stone in 3 months, felt amazing, skin on his arms went back to normal, happiest chap in the world. And he emailed me last week actually, his words were completely over the moon, back in control of his life, no longer a failure. Next case, really interesting. Lady with type 2 diabetes, 75 years old, type 2 diabetes for about 10 years. And she was being treated in a way actually which is pretty typical of people out there. This isn't an unusual situation whatsoever. So she's on 2 drugs for diabetes, and the blood glucose was still above target, so we should probably be thinking about a third drug. She had 2 drugs for her blood pressure, and she was also on codeine for diarrhea and bloating that nobody had diagnosed why. She'd been off for various investigations, cameras up and down, and the taste was affected and really miserable. And she was going on a coach trip to Scotland, which she was obviously looking forward to try and combat her loneliness, but she's nervous about her diarrhea. So again, can you help? What would you do in that situation? So again, following a community event actually, she wanted to try the low carbohydrate diet, looking at how this can be implemented at scale and in practice in a time efficient way without too much cost, combine technology, but she couldn't use technology, she didn't have her phone, she didn't have a computer, so she sat with a health coach once a week to follow this low carb program app. After 1 month, her blood pressure had dropped so much that she had to stop both her blood pressure tablets, which is quite a common effect when you reduce your carbohydrate intake. Her blood glucose had dropped, so she could stop her metformin. And funnily enough, when she stopped her metformin, which does have benefits, again, don't want to make sweeping statements, but her bowels improved, the taste returned, the bloating stopped, the diarrhea stopped, so she could stop her codeine. So she went from 5 drugs down to 1 drug, which we'll be stopping soon. She went on a coach trip, and these are the words out of her mouth: the best I felt in decades, and enjoyed the coach trip, Scotland free from diarrhea. So these cases, Ian was saying earlier on, this is almost boring now because this is what we're seeing on a massive scale. It's not rocket science, and this information's been around for 100+ years. The challenge with this really is how do we provide this at scale, and there is not one route into this, but this highlights why I've decided to spend my time with diabetes.co.uk, the 12-week behaviour change app, which supports people through a journey of changing their diet. But importantly, it's all about solutions-focused approach, what matters to you, goal setting, community, and all the rest of it. But just with this app, 1 in 4 people achieve remission of their type 2 diabetes, which is good. Our best when we hit 70–80%. The impact of this is so great that the reinsurance industry across the world are interested because their costs around their life insurance and critical illness policies are going to annihilate them if they don't do something about it. So we've partnered with them to help them get this product out to the insurers. 1, to help what they call the in-force population, who are just much higher risk than the actuaries predicted, and 2, to try and get people insured that wouldn't otherwise be insured. So that's being rolled out as we speak, and I was in Canada last week helping clinicians understand how to integrate this into their system. Finally, so we talked about obesity, talked about type 2 diabetes. I'm assuming these slides can be emailed out to everybody afterwards. Kind of killed me making this because I'm not a linear thinker in my thinking mirrors what many people have talked about here. But if you look at from a medical point of view, what's crushing our system cost-wise, it's a lot of those conditions on your right. Type 2 diabetes, pre-diabetes, obesity, hypertension, heart disease, stroke, non-alcoholic fatty liver disease. 1 in 3 adults in this country now has a fatty liver. Gout, some cancers, definitely not all cancers, some dementia, Alzheimer's disease is exploding, not because people are getting older, because we're living longer in a certain way. Polycystic ovarian syndrome, all these women out there who are struggling to get pregnant, very rarely do they get talked to about nutrition. Kidney disease. What we do typically is drug all of those and put people in environments which aren't supportive. The answer to this stuff, the answer to a broken healthcare service is staring us in the face. We know what we need to do. We need to support people. We need to build communities. We need to address people's biology in a way that makes sense. And the health service is fixed, and it's actually that simple. So there you go. That's a rush through.
You have the prescriber, don't you? Then you have the link worker.
Yes.
Who are the link workers? What do they do? What's their background?
Their background is really simply, quite often they're people who've been helped by social prescription themselves. So the idea is they're people in the community, they're non-clinical, They often have motivational training, and they're very personable. And that's probably as far as it goes. At the moment, working out a course and a job description. Interestingly, in Holland last week, they had link workers, and they are social workers. They're an offshoot of social workers. They're very much more professionalised. In the UK, I'm not so keen that we should do that. Really, the reasons, come from, which is we don't want to make this too expensive, too professionalised, too much, on a medical model. But crucially, it's their personal skills and motivational training. They have lots of names. In Somerset, they're called village agents, and somewhere they call community connectors, is what they're called in Scotland. They have lots of names.
Thank you. Thank you.
Yes. Sorry, Sally.
Sam, can you give me a typical case study of somebody who might receive a social prescription?
The answer is it's almost anyone. We now spread this, by the way, throughout our Hamlets. I'm the chair of the CCG, so I'm commissioned in all practices. We did a study at the end of last year which showed that every practice is doing 80% of GPs a day over a year period. It's absolutely anybody. You see that actually from all the presentations. It's really about all of us.
What I'm trying to get to is just a picture in my mind of somebody who, what typical problems would you see and what would you describe?
Okay, so if I think of our referral form, so we've got referral forms, we like to make it nice and easy for the 10-minute GP. So what will be listed there, it'll be typically something around weight, loneliness, anxiety, financial problems, English second language, and then a repeat attender. So that's typically what will kick off. What I would say is that as long as the GPs have a light bulb moment of having that discussion with patients, the patients will often end up somewhere completely different, and that's not a problem, because in the process from that 10-minute consultation of just the GP recognising there's an issue way beyond the proxen or a referral to a specialist, actually the focus with the social prescribing team, which is exactly as Mike describes it, will be actually what matters to them. And so actually, rather than traditionally people end up in diabetic clinics or heart clinics or whatever, you could end up anywhere actually under our system.
Paul.
Is there any way we can just put you all in charge of the health service?
We're working on it.
A question I was going to ask was, obviously you've all done really good things in your own areas, in your own patches, but obviously Mike probably knows from all his involvement with the college and the network you set up, it really needs the buy-in of all the NHS managers, isn't it? Clinical commissioning groups. Is that enthusiasm there, do you think, around the country?
It's certainly, there are 12 commissioning groups who are doing it fully. There's one county, Shropshire, that's providing it from local authority. So there is enthusiasm around. What's really feeding us, I think, is not the research, it's simply the numbers. It's the fact the network's gone to 2,002 years. It's the fact that quite a lot of us do have national roles and can shout and beef about a bit. And I think increasingly the problem is that these areas where it's happening, and because you've got enthusiastic GPs, you've got enthusiastic commissioners, managers, and that itself is getting very unfair because what about all the patients, they depend upon having enthusiastic GP or enthusiastic commissioner. And I think that's going to be the thing that will drive universal access very quickly now.
And has any of the other panelists got anything to add on that? Campbell?
Just one of the things that comes out of this difference in relationships is community building itself and starting to lobby back to CCGs and the people who hold the purse strings. So I think a lot of it is about this kind of the social movement stuff, isn't it? And changing expectations and driving from the ground up.
And do you feel more hopeful with this new Minister of State? Who's actually
Well, very much so, yes, because he said 2 weeks ago at the Expo he wants universal. And he wrote to me 2 days ago saying he wants to come and speak at the second national conference on social prescribing on November the 6th. So I think we've got a really good headwind of senior people above who get it. The problem sometimes is the people in between.
Yeah.
But it's very interesting about this commissioning. We're getting what I almost call delinquent commissioning. That's the commissioning has lost its way nationally. It's become very testosterone fueled with large tenders and everything else. What's happening here, so in Rotherham, is the patients and link workers are finding areas they want to expand in terms of the volunteer and voluntary sector, and the commissioning group is paying for that. They're paying for things that the CCG at board level would never have paid for. So it's becoming, if you like, patient-centred commissioning at the front line.
Jerome and then Jane. Jerome.
You're all enormously charming and plausible and hugely emotionally intelligent and so on. And this obviously is why you can generate all this enthusiasm and get all sorts of people to work in different ways. Are you clonable? Is it possible to distill the essence of your abilities and insight and compassion and give it to doctors, many of whom perhaps came into medicine with 4 A's in the biological sciences and so on, who perhaps aren't so strong in these areas? What happens with that?
Yeah, I think from my perspective, working indeed in academia and teaching a lot of health and social care professionals, one of the crucial things we are seeing now in a lot of universities, and indeed with the social prescribing network, which is something we're working on as well, with really enthusiastic students themselves too, is co-creating and reformulating the medical and social care curriculum to firmly integrate exactly these crucial things that are needed to foster compassion and empathy and good communication skills, to really foster also that therapeutic alliance with your with the person you are working with, and with your communities, reaching out, that partnership thinking, that collaborative thinking, which is often, someone mentioned, I think all of us probably mentioned siloed working, is disastrous, and it's not working. It is not working. So firmly embedding this in the medical and other caring professionals' curricula is absolutely important, and it is happening. There is definitely that shift, even in the more traditional environments.
And Ian, you must be seeing this in your courses at the RTGP.
Yes, I mean, it's interesting because a lot of the people that come to those courses are already half in that model because they come along because they're interested in lifestyle medicine, or they realise that there's a bit of a knowledge gap in what they're doing, or they're frustrated, or they're looking for something else. But and so the first one that we did in January was basically a bunch of, not our friends, but people that would go to that kind of course anyway. The second one in April was really tricky. It was a bunch of cynical, old school, hard-nosed sort of GPs that were like, right, I'm here to prove this, that this whole thing is BS, and it was, you could feel it in the room. They were all dead quiet, there was no buzz, and we were like, oh my God, this is going to be tough. But people started coming up to us at the end by saying, I came here really cynic, and I'm absolutely sold. You can't get it across in 10 minutes. I think I tried to cover it too quickly, but there's a narrative arc to it through the day. It's not one of these conferences where someone talks about their thing and then the next person talks about their thing. It's tailored in a way that it's like I said, it's like installing software, but which has got a benign effect. So yes, I think you can crack these tough nuts, but it takes that grassroots level investment, medical schools and changing the culture of medicine, which I think is not a thing that happens overnight.
And I remember when I was writing about social prescribing, talking to Michael, who's having a quick conflict exam, about the fact that it actually benefited the GPs, and that's something that Helen was touching on as well, that it's as much about caring for the deliverers of healthcare. And Helen, I wondered if that was something that you noticed was having an effect.
I think certainly within our scheme, people feel a sense of ownership. The community owns what's happening to it, and we feel proud of the work that we're doing, and we feel empowered to be able to deliver that. It doesn't take me longer in a consultation to ask what matters to somebody and then have a conversation. People have thought in detail about that before they come and see me, but now I've got the tools and the resources to be able to work with them with the direction that they thought they wanted to take, rather than have to impose a medical model which doesn't fit with what they wanted to do.
And I think it makes it more satisfying, but also the consultation can be shorter, because instead of talking about how many bits of lettuce they eat during the day, you say, go and see Ruth, you'll sort out your problem of weight. But on students, and it's interesting, is we're finding the students have these ideals. They have them pumped out of them by the system. And so Bogdan, who's our College of Medicine lead, now has students in every single medical school, and they are rewriting the curriculum. In fact, just as we speak, we're coming up with a curriculum in the next few weeks, which will go to all medical schools, and then the students will monitor whether the medical schools are doing their bit in giving them a proper psychosocial background from the beginning.
So
Just revolution.
we've just done a study among our GPs to find that Tower Hamlets GPs are 20% more joyous. So it's has an impact in all directions.
Sorry, sir. We've got time for 2 more questions, and I'm afraid it is Jane.
Well, I was going to ask the same sort of.
Barbara, did you want to?
Well, my question has almost been answered. I was going to ask, how soon are we likely to see this really embedded in schools of medicine, so that it gets really pumped into them?
Can I explain briefly on that? I just spent last year teaching first year medical students at Bristol University. The course was called Effective Consulting, but it was about consulting with your head, heart and hands. And first week we were talking, we were teaching on what matters to patients, and the power of the relationship, which is a completely different model than certainly when I trained. So it's happening now. And just also fitting very briefly with the previous question, which ties into this, clinicians, like people, need awareness, knowledge and support to make changes. And I think what's happening now is we are seeing a massive surge of people, clinicians wanting hope that their life isn't going to be 40 years of misery and then retire. It's just knowing how to go about it.
Right, now 2 questions, sorry Mary Claire. Jackie, and then Tessa, and then I'm afraid we do have to go and eat supper, or else it'll get cold or something. But lots of time for networking and more questions with all the speakers afterwards.
And so my questions for the whole panel, I'd like to thank you all for the really joyous, inspirational, wonderful examples and so on. But would you also permit me to be a bit controversial and play devil's advocate, which is that, for the last few decades we've been told medical science is the holy grail, and we're being told that traditional medicine practitioners, complementary practitioners who focus on what matters to the patient, diet, lifestyle, relationships, etc., are all quacks. Isn't what you've been saying tonight what they've all been saying for ages, and it is, as you say, just the same old, same old. And the case studies are a bit of an example, because with all due respect, and they're lovely, and I'm so happy for those people, but a first-year nutritional therapy student would have been saying exactly those things to Ian and Dr. Campbell's patient. So it's terrific, but with all due respect, isn't it that the medics are now taking that and just giving it a prescriptive label and calling it something great, like social prescribing? And I'm just playing devil's advocate, but I'd love to hear your responses. Thank you.
So I was challenged to actually hear from somebody very senior in public health, with lots of people from the NHS, about the name of social prescribing. What I said then, and I'll say to you now, it's a grand conspiracy, by the way, to re-educate the whole of the medical profession. That's why we call it. So don't be under any illusion this is what it's really about. You're quite right, actually. Everyone was saying this 20 years ago in the complementary therapy arena. Actually, what we've got to do is re-educate the whole profession. And my final point would be, if patients in Tower Hamlets, okay, if you are poor, you can expect to reach the age of 75 at the age of 55. It isn't the magic of cancer cures and everything you see in the press all the time. It's absolutely about what we're all talking about. This is the thing that really is going to make the change in people's life. This is real modern medicine. When you start looking at the figures of every 1,000 patients that you treat with antihypertensive, actually how many strokes are actually saved, it's pitiful actually in terms of the gains that you can get from what we're talking about. And I think I would define now social prescribing as an infectious process now within the whole system. There isn't a person who doesn't talk about it within the system, even Simon Stevens, the Health Minister, Jeremy Hunt, actually, when he was in place, very specific about it initially. Now, it is absolutely ingrained, it's infected, it's reached that take-off point, I would say, of, well, at least for GPs, who take at least 20% around the country. And it has, by the way, it happens everywhere. Because often people will say to us, actually, it's just about us. Angela Lennox has got a police station in her waiting room as a GP, reduced crime on an open housing estate to 20% what it was. A friend of mine in Scotland sent up a co-op and had a hairdresser in their waiting room. It doesn't look the same, but actually it's almost everywhere now in people's psyche across the medical profession.
Can I just also say very quickly, the one thing that complementary practitioners have that we have never historically had is time with the patient, you know. And one of the benefits of social prescribing is that you're giving someone quite a lot of time. Actually, my social prescribing team at our surgery often have a much bigger effect than I can ever have with any intervention, even if it's an elimination diet or whatever you want to call it. The other thing is that actually medicine has changed, the planet is changing, and the patterns of disease are changing. And these are things that we read about, you know, in the press. Oh, you know, plastics are leaching into our systems and affecting our hormones, and that's why you get low sperm counts and all that sort of stuff. But actually, how do you apply it to the person in front of you? And I think, you know, there are those two elements